Good evening, everyone. We have today with us our esteemed speaker, Jason Payne James. Welcome, sir.
Good evening, or good evening to you all from Essex and the east coast of England.
So, thank you so much for accepting our invitation for delivering a lecture on role of forensic physician in United Kingdom. So, here we are welcome in this international lecture series on behalf of Sherlock Institute of Forensic Science. I welcome you along with my co-host Dr. Pooja Chakravarti, and I request Dr. Pooja Chakravarti to read the introduction about our esteemed speakers. Today's esteemed speaker, Dr. Jason Payne James. Dr. Pooja Chakravarti, over to you.
Sure, sir. Today we have with us our esteemed speaker, Dr. Jason Payne James. He's a specialist in forensic and legal medicine. He has been a forensic physician for 30 years. He qualified in medicine in 1980 at the London Hospital Medical College and undertook additional postgraduate education to higher degree level at Cardiff Law School, the Department of Forensic Medicine and Science at the University of Glasgow, and with the University of Ulster, Northern Ireland. He is Director of Forensic Healthcare Services Limited, and he was President of the Faculty of Forensic and Legal Medicine of the Royal College of Physicians from 2015 to 2017 and the World Police Medical Officers from 2011 to 2014. He is Honorary Professor at the Department of Forensic Medicine, University of Belgrade, Serbia. He is Honorary Clinical Professor at the William Harvey Research Institute, Queen's Mary, University of London, UK. He is a lead medical examiner at the Norfolk and the Norwich University Hospitals, NHS Trust. He is expert advisor to the UK National Crime Agency. He is an independent member of the Scientific Advisory Committee on the Medical Implications of Less Lethal Weapons. He is an independent researcher, an author, an editor, and initiates, leads, or has collaborated in research projects with a number of organizations, including the Independent Office for Police Conduct, the Metropolitan Police Service, and the Home Office Center for Applied Science and Technology, and the National Crime Agency. He is co-author of Faculty of Forensic and Legal Medicine documents, including those to medications management in custody, management after exposure to taser, and irritant spray, head injury, and choking. Jason has developed, co-edited, co-authored, and contributed to a number of books, including the Encyclopedia of Forensic and Legal Medicine, the Forensic Medicine Clinical and Pathological Aspects, Symptoms and Signs of Substance Misuse, in its different editions, Artificial Nutrition Support in Clinical Practice, Symptoms and Early Warning Signs, Medico-Legal Essentials of Healthcare, Color Atlas of Forensic Medicine. He is co-author of the 13th and 14th edition of Simpson's Forensic Medicine. He co-authored the Oxford Handbook of Forensic Medicine and co-edited the both Age Estimation and Living with Professor Demi Sue Black and Professor Anil Agarwal, and Current Practice in Forensic Medicine, a third volume co-edited with John Well is underway. Together with Joe Banion and Duarte Novera, their book Monitoring Detention, Custody, Torture and Ill Treatment was highly commended in the BMA Medical Book Awards. Thank you so much, sir, for accepting our request of joining this session. He provides expert opinion and advice for defense solicitors, the police, the Crown Prosecution Service, Service Prosecuting Authority, HM coroners, and the other agencies in the UK and around the world. He is frequently asked to act as an expert witness in the range of settings. He has been involved in many high-profile and sensitive cases, including miscarriages of justice. He provides pro bono support in a number of cases for individuals and campaigning bodies and appears frequently on broadcast media. With this, I would like to request sir to take on the session. Thank you so much for being with us.
Thank you so much, Dr. Pooja. Now I request our esteemed speaker to if he wants to do the screen share, or how we can proceed. Can I proceed with the video, recorded video which you have shared? Sir, can you unmute, sir?
I'm unmuted now. Yes, thanks very much for that kind introduction. Yes, I think let's proceed with the video. I apologize to everybody. It's about 70 minutes long, and the reason that we're doing it as a video is that we've got very bad weather here in the east coast of England at the moment, and I was concerned my signal might drop out when speaking. So we'll listen to the video, and I'm happy to take any comments, questions afterwards for as long as you like. And equally, I'm happy for anybody in the future to email me, and very interested to hear what you feel about what I say. Thank you.
Thank you so much, sir. So now I'm sharing the video, and I hope it will be streamed properly. Visible to everyone?
Good evening.
It is visible.
Well, I'm going to talk to you today tonight about the role of the forensic physician in the UK. But in fact, what I'm going to do is try and give an overview of the kind of work that I'm involved in and how it interrelates with a lot of work of people that are not forensic physicians, such as forensic scientists, forensic odontologists, forensic pathologists, just by giving an idea of my workload. So basically, I'm what's called a forensic physician. I'm based in the United Kingdom, and I'm also a specialist in forensic medicine. Now,
I think there is some problem and in the sharing. Let me check once again. I think the played video was not visible. So I'm just facing this issue in making this video live. And, let me try once again. Is that video is visible to the participant? Can anyone write a message in the group? So I will start playing.
So the screen is visible now properly.
good evening. Well, I'm going to talk to you today tonight about the role of the forensic physician in the UK. But in fact, what I'm going to do is and I'm also a specialist in forensic medicine. Now, perhaps just to give a little bit of history behind this. What is a forensic physician? Most people, if you say I'm a doctor who's working in forensics, will assume that you may be either a pathologist, that is doing autopsies, which I don't do, although I sometimes get involved in them. They may think you're a forensic odontologist, as I know some of you are, or forensic anthropologist, or indeed forensic scientist. The term forensic physician, for some reason, isn't particularly well known, although it's been around for about 50 years or so. And it originally started, certainly one of the bases was in the United Kingdom, where the term police surgeon was used. The term police surgeon, slightly older one, but it was for doctors who were assisting the police when, for example, they had prisoners who required some form of medical attention. So it was a community-based role in some respects when first started assisting the local police forces. And the terms that we used were police surgeon, although most people weren't surgeons, police doctor, a divisional surgeon, and most of them were drawn from what we call general practitioners or local family physicians. So really it was a kind of community support for the police. Nowadays, it's been really important for us to gradually develop and emphasize our independence from the police or indeed anyone else, and to show that we are independent doctors with opinions of our own, and that we're not constrained by whoever is paying or employing us. And so the terms that is broadly used for a forensic physician, the roles that are allotted to people may be called forensic medical examiner. The term medical examiner, again, is a little bit confusing, unfortunately, because, of course, in the States and around the world, the term medical examiner actually means a forensic pathologist. So it's always important, I think, when you're talking about particular roles, to define what you mean in a particular setting. So I'm talking about doctors who are not pathologists. So the term forensic medical examiner is used. I'm a forensic medical examiner in London, in the UK, part of my time. In Northern Ireland, for example, the term forensic medical officer is used for the same role. And then there's a group of people who are engaged in forensic medical work, but are limited to those examinations and support of people who are complainants of sexual offences. In the UK, in 2005-2006, a faculty of forensic and legal medicine was established, really to bring together and set standards for how all doctors working in the field to try and identify appropriate standards for them. And there are three main groups of what we call forensic practitioners: the forensic physicians, which include people like myself doing general forensic medicine and sexual offence medicine. And in fact, there are a group of forensic pathologists, some forensic odontologists, and some forensic psychiatrists who are also members or fellows of the Faculty of Forensic and Legal Medicine. Other groups that are involved within this are medico-legal advisors and dento-legal advisors to medical and dental defence organisations. And then a small proportion, slightly diminishing proportion, are medical coroners. And again, important to know that I'm referring to coroners in the England and Wales jurisdiction. Coroners are independent judicial appointments, not as they are, for example, in the United States, sometimes elected political appointments. So again, definitions, all of these very, very important. Anyway, I hope that has not confused you too much. It's confused me, but hopefully not confused you. And the Faculty of Forensic and Legal Medicine has two main objectives: to promote for the public benefit the advancement of education and knowledge in the field of forensic and legal medicine, and to develop and maintain for the public benefit the good practice of forensic and legal medicine. So forensic physicians work within the field of forensic and legal medicine in the UK. And we consider our role is to raise standards in forensic and legal medicine, and in particular to protect vulnerable people, whether they're detainees, complainants, victims, or whatever the people we're seeing. So again, to just expand on what a forensic physician is, for those of you who don't know, first of all, I want to say that we consider ourselves and have to be independent and non-judgmental. When you're dealing with criminal matters, when you're dealing with perhaps perpetrators or suspects of crime or victims or complainants of crime, it's very important that your medical independence is justified, and it's not swayed by either the person you're examining or indeed people who are employing you or asking you, requesting you to make assessments. So, for example, the courts or judges. So we practice, and again, this is to differentiate from forensic pathology, we practice clinical forensic medicine. That is forensic medicine in the living person. And most of our work will involve in some stage, at some time, the police, legal system, tribunals, the judiciary, but always, pretty much always, dealing with the living person. Often for some doctors, it may be a subspecialty interest, for example, somebody working within emergency medicine or as a primary care physician, as a general practitioner. But for a number of us, that is our main workload, and we are specialists in forensic and legal medicine. Stan Burgess in 1978 wrote a book called The New Police Surgeon, which was the first real textbook for forensic physicians. And that is where, as far as I'm aware, the terms clinical forensic medicine and forensic physician were really first placed within reading matter. So what can we do? What are the kind of things that we do? Well, it may include the forensic assessment of detainees in police custody. So it could be somebody who's been arrested for theft, somebody who's arrested for murder, for rape, for child abuse, for trafficking, female genital mutilation. Somebody who's been arrested for a possible offence and is being investigated will be taken to a police station, then turned to be in police custody. And they may have medical requirements, there may be forensic requirements, sampling requirements. That is one of our roles. And the same goes for those who are complaining of, for example, assault, sexual assault or rape, or who, for example, have been stabbed and taken to hospital, where the treating doctors will deal with their main injuries, but we will be there to monitor and take appropriate forensic samples. We also get heavily involved in safeguarding, so we may see younger people who have been arrested for whatever reason, and we have a duty to ensure that they are safeguarded through the various safeguarding mechanisms that exist in England and Wales and Scotland and Northern Ireland. And then we're specifically responsible for the medical care of detainees in police custody. So there may not be any medical requirement, any forensic requirement for us to see them, but they may, for example, have diabetes, chest infections, high blood pressure, previous heart problems, and those may require appropriate medication whilst they are in custody. What we also see, because of general migration and displacement of people from countries, we may see torture victims, refugees, asylum seekers, and we may be asked to assess those. This doesn't happen. All these roles may not apply to everybody, but they can apply to all forensic physicians. We may assist and assess police officers who've been injured in the course of their duty or who've been involved in complaints where it's alleged that they have harmed someone. We give written and live evidence to courts and tribunals and any other legal setting. And some of us, the more senior ones, may be expert witnesses giving opinion evidence as opposed to just factual evidence within those courts. There are a number of other specific settings, so a coroner's court, which may be undertaking an inquest. What was the independent police case commission, but is now the Independent Office of Police Conduct. Assorted inquiries or commissions, we may be asked to give opinion or evidence to those. The Prison and Probation Ombudsman, which looks at people in long-term custody who've either been sentenced or remanded pending a court case. Then perhaps in areas, all of these will involve other disciplines such as forensic science, so we will take samples which are then given to those of you who are forensic science. We may take scientists, we may take biological samples, we may take blood samples for toxicological analysis. And it is very important those samples, as you know, are taken rigorously, appropriately, documented accurately, and a chain of custody is established. And when that doesn't happen, when a forensic physician doesn't do their job properly, or a forensic scientist may not, or a forensic toxicologist, or forensic anthropologist, or forensic odontologist, their evidence, or our evidence, may be challenged, and we may find that old cases are being reviewed, historic cases, cases where, for example, there have been public concerns about whether or not there's been a miscarriage of justice. Actual miscarriages of justice, which have been pursued through the courts, may require re-investigation or re-review by each of us in our different roles. But I think the most important thing to remember for all of us, for those of you listening today, for me talking, is that all of us are just little jigsaws in a much bigger legal and judicial setting. And I think it's always concerning when any of us in our particular fields sometimes think that perhaps we're the answer to all the questions that the courts need. I like to think that I have a relatively small role. If I get it right, I can assist to make sure that justice is appropriately done, whether that means somebody is acquitted appropriately or somebody is found guilty appropriately. It's not my role to determine what's right or wrong. My role, as your role is to ensure that the proper evidence is put before the court or tribunal or whatever to be interpreted by the courts. I didn't mention, but the Faculty of Forensic and Legal Medicine, as you see on a previous slide, does have a website, and there's a lot of standardized publications that set standards, identify standards in the area of work in which we undertake things. And then this link here gives a little bit of better explanation of what a forensic physician can do. So many people, because they haven't heard the term before, say, oh, is this a new thing? Is being a forensic physician a new thing? Well, I always like to say I refer to Graham Grant's book, The Diary of a Police Surgeon. You see where this red arrow is, you'll see that was published 100 years ago in 1920. And for me, the rather nice thing about Graham Grant is that he was a police surgeon, as they were then called, in the East End of London. And in fact, this is the area in which I work. I'm working when I'm working for the Metropolitan Police Service in London. And I work, or certainly up until a few years ago, worked in many of the stations, the Victorian police stations that he would have worked in 100 years ago. So is there anything in the Diary of a Police Surgeon which I think can sort of explain what we're doing today, or did they have completely different values? If we look at one of the stories that he talks about in his role as an independent police surgeon, he says he was called to Shadwell Police Station and to see a man charged with being drunk and disorderly. Still a fairly common occurrence, and who had a number of wounds on the top of his head. He'd been in a fight. So the doctor says, I dressed the wounds and bandaged the dressings. Remember, this is 100 years ago, to our mutual satisfaction. And when I had finished, he, that is the prisoner, said, Doctor, you might come with me to the cell door. So the doctor says, I saw no reason to refuse his request and went with him. We were just passing the door of an empty cell when a police constable, the mop,
slipped out and struck the man a blow over the head, which made short work of all my beautiful bandaging. We don't know why he did this, but he was being assaulted by a police officer at the station. And what I think is very reassuring is that even then, 100 years ago, the doctor, being independent and non-judgmental, says, boiling over with indignation, I hurried to the inspector's office, told him what had occurred, and added that if he did not deal with the delinquent, that is the police officer who hit the prisoner over the head at once and sufficiently, I would report the whole disgusting business to headquarters. So even 100 years ago, doctors were well aware that their responsibility was to the patient that they're treating. And that's how I try to think of everything that I do. Whoever I'm seeing, whether they've been somebody who's been arrested for murder, whether I see somebody in a prison who has been charged and convicted of multiple rapes, my role as a doctor is there to be independent and non-judgmental and to treat them in the same way as I would anyone else. Another thing perhaps of interest is how has forensic medicine changed over the years? So on the left-hand side here, we've got the Encyclopedia of Forensic and Legal Medicine that Roger Bayard and I edited, the second edition, a couple of years ago. And if we look at the context of that, it's really not that much different from the Principles of Forensic Medicine, which was published 200 years ago, 199 years ago, it'll be 200 next year, in 1821. The main advances are not actually in the forensic medicine areas, but much more clearly in the forensic science, forensic anthropology, and the forensic toxicology areas. But I'm afraid that poor old forensic medicine, whether you're a forensic pathologist or a forensic physician, it's difficult to find any massive advances in what we've been doing over a couple of hundred years, which is a bit disappointing. But it still means that the emphasis of our work has to be on proper clinical and physical examinations and documentation of what we do. So just a little note on the legal aspects in England and Wales, certainly, and that is following a number of miscarriages of justice in the 1970s, particularly related to what were referred to as the Troubles in Ireland. This is where there was substantial terrorist activity by both paramilitaries, and some miscarriages of justice where those who had been arrested were treated inappropriately, false confessions were got, and so substantial understanding of where things went wrong within the police setting resulted in what's called the Police and Criminal Evidence Act, sometimes known as PACE. And one of the things it did, apart from explaining and putting in statute how police have to investigate and look after detainees who have been arrested and for possible crimes, one of the things that was included in that was the requirement to see a doctor if they appear to be suffering from a physical illness, this is the detainee, or they're injured, if they appear to be suffering from a mental disorder, or they need clinical attention in any other way. So that very broadly is the framework. Anybody arrested, and in fact this pretty much applies around the world now, those who are arrested should have the opportunity to see a doctor. Sometimes it may be a nurse or a paramedic. As, for example, the law has changed in the UK, in England and Wales in the last few years, but they should have access not only to legal advice, but also medical support. So that's the basis of where a lot of our forensic physician work comes from. And what's different in forensic medicine from, say, I don't know, cardiology or gastroenterology or any of the other big medical specialties? Well, the main thing is perhaps that we have more forensic healthcare issues. What do I mean by that? Well, I mean that many of the people that we see in police custody may have significant alcohol problems, they may be dependent on heroin and crack cocaine, benzodiazepines, and in fact, many novel psychoactive substances. And so this was a little study we did quite a few years ago now. But what we also found was that many of our patients also had non-forensic healthcare issues, so the things that all of us may have, or a normal population might have, which include diabetes, epilepsy, cardiac and respiratory problems. The problem is, because of the forensic healthcare issues, sometimes there may be an associated chaotic lifestyle or difficulty in accessing medical care. And so often these conditions may be poorly treated or out of control. And so our role in that setting is to ensure that people are getting appropriate treatment. And many may have been prescribed medication but are not compliant with it for some reason. It may be simply because they can't pay for the drugs, they can't access the drugs, or they've lost their prescriptions, and they have no contact with their doctors. What it does mean is that people who are forensic physicians should have, more than other doctors, I believe, a much better understanding and knowledge of drugs. They need to know what are the effects of drugs. So if we look here on the left-hand side, this man has very dilated pupils. This is because he'd recently taken some stimulant drug. On this side, we have pinpoint pupils on the bottom right, because that person had taken opiate drug, in this case, recently taken heroin. And then we also need to know and recognize drugs which may be in people's possession. So, for example, this was not, well, I suppose it was in possession, but these represent little 2 by 1 centimeter or so wraps of cling film wrapped lumps of cannabis. And this was a group of about 48 that were removed from a person's rectum. This is crack cocaine, very widely used in the UK. Again, every country has its own different spectrum of drugs that are used. We haven't had, for example, the amount of methamphetamine, crystal meth, that's used in the States, but our different population areas are particularly, we have a high proportion of heroin and crack use. So that's not unusual. Here we have some leaf cannabis. So it's important for us to understand not only how drugs may present, how they may be administered, they may be smoked, they may be snorted, they may be injected, but also to know their actual effects and also the side effects that they may have. This just simply shows how ordinary day-to-day objects may be converted into things like crack pipes. And this is a miniature whiskey bottle that's been converted into a crack pipe. And this is actually a Ventolin inhaler, a salbutamol inhaler for asthma that also has been converted into a crack pipe. So we have to be aware of these things. We have to have a much greater knowledge of what the interaction in between those may be, because the risks and the side effects and the complications of drug misuse, particularly mixed drug misuse, may be fatal. Another area that we are particularly keen to ensure is done properly is recording or documenting the evidence that we have. So that means that more than any medical specialty, I believe it's essential that when we see and assess something or someone, we have clear written accounts of what we've done. Our medical notes are that if there are people with injuries, that we may use body diagrams, we may use photography. Rarely now is it print, mainly it's digital, but the way in which those photographs, those images are taken, they need to be done in a forensic way. And so anybody who's taking photographs for example, forensic purposes, should be trained to do that. We may see evidence recorded, for example, colposcopy examinations when sexual assault victims are examined. Those may be recorded in video and stored on DVD. Increasingly, there may be other electronic versions of recording data, such as apps. Many police officers and increasingly some healthcare staff now wear body-worn video. This is not necessarily what we would be recording, but if we are looking at a case and trying to interpret something and trying to give our opinion on it, then it's important to be aware of what other sources of information may be available to us, which we can then use to inform our opinion. As with all these things, the storage of all of this private, confidential data is crucial, and it needs to be securely done. Again, you need to be aware in your own jurisdiction how it's done, and I'll come towards the end about where the preservation of evidence has resulted in some problems. And then you also have to know is when, if that data is in your possession, when can you properly disclose it and allow it to be reviewed by others? And again, many of these things, the broad principles are the same. So for example, in medicine, you cannot do things without consent, and medical data is confidential with certain exceptions or with the permission of the person whose data it is. Again, these details are things that we can't go into now, but are very important principles. This is just the kind of pro forma that I would use if I'm seeing something in police custody. Gives the name, the details, but then I record down things like their past medical history, past psychiatric history, drug and alcohol usage, what they've used in the last 24 hours, and then the physical examination and whether, for example, I've assessed them ever before, whether I have any previous arrest information, and then more specific factors about substance misuse. If somebody's withdrawing from drugs or withdrawing from alcohol, there's sometimes an increased risk of things going wrong, increased risk of death. So everything needs to be documented. This is a simple body diagram I do if there isn't any substantial amount of injuries that can be done on an A4 piece of paper. But if we need to record much more detailed or complex injuries, then we can use a series of body diagrams. This is a series that I created last year. There's about 32 in the entire series, and in fact this will be used in the new version of the Istanbul Protocol. We've tried to develop a series of very useful body diagrams that can be used in all settings. Now, again, one of the things which, if you are a doctor or a head nurse or a paramedic not working in the forensic setting, the measurement of injury, the measurement of marks on the body isn't really very important. Those of you who are forensic scientists or odontologists or forensic pathologists or forensic physicians will know that sometimes the precise measurements of a particular object or a particular mark on the skin may assist in connecting that in terms of pattern or size to an individual or an implement. And so it's very important. And I put up here forensic graph. Some of you may know this is something that I created, but the purpose of this is because it has color values, it has size things, it enables you to get fairly easily just an accurate sizing and recording of the nature of an injury or a wound. And here we have just an example of a patterned bruise and abrasion where a man presented to police having been assaulted, and he had these two little, almost look tooth-like. I'm sure those of you who are odontologists will agree this is not teeth, but two little squarish marks, bruising and a little bit of edge abrasion. And in fact, by measuring that and advising the police what was needed to be looked for, this broken chair leg was found to be the causative implement in the assault. This person was quite seriously assaulted otherwise, and that this was able to be linked to not only the assailant, but also the victim. Here again, typical kind of injury you might see here. There's a very clear pattern. The other marks or abrasions or bruises over here, if we didn't have that one, there wouldn't be a pattern. Here it's much more random. But again, the important thing is this needs to be documented accurately, it needs to be documented appropriately and interpreted in the correct way. Here, again, this is to show somebody who was trying a new drug. He didn't know what it was. We never found out what it was, but he had been told just to rub it on his lips. He rubbed it on his lips. Within about 5 or 10 minutes, he developed this very swollen edematous lip. And he'd also developed some difficulty in breathing. So he had an allergic reaction to it. He was brought in, given some intravenous steroids and some antihistamines, and this all settled down. But again, I use this to illustrate that the appearance of an injury can change quite rapidly and markedly. Again, for us, it's important to make sure you document it at the time. Here again is another nasty wound, a razor blade slash wound to the side of the face, the side of this person's face. This is the poor quality image taken by either the person himself or a friend at the time that it happened. And then this is the appearance after surgery. And I think that sometimes this appearance after suture and surgery means that you don't realize how dramatic a particular wound is. And sometimes it may be important in a court case for a judge or a jury to realize that what looks like a fairly benign, although perhaps lengthy wound, was in fact very unpleasant and could have penetrated through his facial nerve and caused paralysis and all kinds of things. I refer to electronic documentation and recording of data. Forensic Doc is an app that I designed, which is just going into its second iteration. We're just working on that at the moment. But there are others, I'm sure, available. But the purpose about this is that if you come across an incident or an injury or a wounding, or you're not in a setting where you have access to paper and desks and things like that, if you've got your smartphone or iPad or some other, that you're able to record all your findings, and it's all geolocated, it's contemporaneous. You can write and document your findings from the app. You can pull out a series of body diagrams and record the findings. It's a person who's been injured, and then you can take images and video and audio. What this then generates is immediately in a secure system. It goes up the cloud and is bounced back again, but it creates a Word document, so you've immediately got access to an editable Word document to produce a report. Now, I know that there'll be a number of forensic odontologists watching. I'm the first one to say that I'm not an expert on either bites or teeth marks. However, as a forensic physician, I encounter many bites, both human and animal. And although I defer to yourselves as forensic odontologists for specific advice on the nature, teeth, age of individuals, and linking bites together, I also sometimes have to say, so for example, this man was punched to the left side of the face, and here there's just imprints or abrasions from his teeth. So we will look at bites and teeth marks, and here I may be asked to comment on what was the force required to remove that piece of the earlobe or that piece of the lower lip. So I won't be saying that particular wound was caused by somebody or those particular teeth. I will say, well, this is the kind of force required and the mechanism required to create injuries like this. But things like this, where there may be dental arches and teeth imprints, these these are the ones where, if there's a question of identification, these I would defer and ask forensic odontology colleagues to opine on. So what other areas do we get into? And again, I'm being very general, just to give you a flavour of the work of a forensic physician. And although the title of this is Forensic Physician in the UK, I know that around the world, most of my colleagues will be covering this kind of work and doing a similar kind of role, sometimes extended, and some may in fact be pathologists also themselves. So public order and restraint, well, this particular year, 2020, I think has been one where we've seen substantial upheavals all around the world. This image was actually taken about 10 years ago in London, and riots in London tend to be a much calmer affair, perhaps, than riots in some other countries, or have been in the past. But I think that's changing. I think there's a degree of unease around all countries. And I think in terms of how you control individuals or groups of people who don't want to be controlled is becoming a much more generic worldwide issue. So this was riots in the summer. There was much damage to buildings and people, and attacks on police. And so in the UK, we have a fairly limited number of ways of restraining and controlling people, but all of them have their effect, but also may have side effects and complications. And we are there to ensure that any of those complications are appropriately treated and dealt with. And so they may come from rigid handcuffs, they may come from plastic wrist restraints or body cuffs, spit hoods, irritant spray, CS and PAVA, sometimes just simply empty hand, unarmed combat, and positional restraint, which itself has its own risks. We may have police batons, we may have taser, we may have water cannon, projectiles, attenuated energy, projectiles such as generically known as rubber bullets, and canines and dogs themselves. And in the UK, we do try and record use of force. If use of force is required to restrain or detain someone, then that needs to be documented, and is documented within the custody record. And we will almost invariably be asked to see somebody if there are injuries. This image was actually in central London this afternoon. Today is the 26th of September, where there are masses of riots. Today, this relates to anti-maskers, people who don't want to be socially distanced. All countries are dealing with COVID in different ways. At the moment, we have a kind of curfew at 10 o'clock, and people are expected to socially distance and to wear masks in particular venues. There's a proportion of the population who don't agree with that. And even as I speak, there are riots going on in central London. The police are having to restrain and detain a number of people. So a baton is sometimes referred to as a nightstick. There's a variety of different ones. Some are made of acrylic, some of wood, some of metal. This is one where somebody's been struck with an ASP baton, that is an extendable metal baton. There's places where people should be hit to try and control them. And these are generally on the limbs. People shouldn't be struck on the head normally because there is a risk of skull fracture, but this is a laceration caused by direct impact from a police baton. Not quite related to our police services, but some people who are detained for whatever reason may be subject to things like whips from a variety of different sources. It may be rigid whips, it may be, as in this case, this was electrical, 1-inch electrical cable And this man developed a number of tramline bruises. Again, they need to be documented and they need to be accounted for. Taser is something conducted energy devices. In the UK, Taser is the one that is licensed by the police force, and there's an increasing amount of usage of Taser because we have generally an unarmed police force. So our majority of our police officers don't have guns. So there are a range of other restraints techniques. So Taser has been used for probably about 10 or more years now, and there are different types of Taser. X26 is being phased out. X2 is being used at the moment, and approval has just been given for the Taser 7. The interesting thing about all of these is they have slightly different characteristics and slightly different operating ways. Each of those needs to be assessed to determine what injuries might be sustained from them. And the big concern about any form of Taser is, will it cause some form of cardiorespiratory arrest? There have been many instances of where deployment of the Taser has been associated with a death and a cardiorespiratory arrest. Generally, this will be with somebody who is acutely behaviorally disturbed. So there may be a number of other issues like mental health, somebody being on antipsychotic drugs, maybe also have taken illicit drugs such as stimulants, may have underlying cardiac problems. It's quite right that every death in custody, every death as a result of police contact should be investigated properly. But for those of us who are forensic physicians, understanding what the risks are, the use of Taser are very important. Taser works by firing, in essence, two probes. These are two of the types of probes that then embed themselves. They're connected by a wire to the Taser gun, and then a 50,000-volt discharge is discharged, which causes immediate neuromuscular incapacitation. That person collapses, and then they can be restrained. This is the front of the chest of somebody who's just been tasered, and the two barbs or the two probes have been removed. This is one of the impact sites, and that is another. This man, though, however, the probe landed, he was a 16-year-old boy, the probe landed on his left forehead and penetrated the skull bone actually into the brain. So this is just to illustrate that Taser probes can be quite dangerous and could result and may result in fatality. Irritant sprays, we use CS spray or Parva spray, but our police officers are equipped with small canisters as part of their personal protective equipment. And again, there are side effects to that. And so this is an immediate bullous reaction to Parva spray that's been deployed when this man was detained because of his behavior. There's a number of longer term effects, for example, to eyes, perhaps to breathing, which may be present, but the amount of research that's been done on these areas is quite limited. It's always, I believe, a fruitful area for research for any student wishing to look at what happens. And if you look at it in your own country, it may provide quite a lot of useful evidence for around the world. Increasingly, this is an image from Chile earlier this year, tear gas, a CS Parva spray, kind of sprays that are being used, are used as munitions and used to crowd control rather than the personal protective equipment, which is for individual one-on-one protection. And this is an image from Iraq earlier this year where a canister has actually penetrated the skull. So there are risks to all these things, and we need to be aware of them and to make sure the police are aware of them. Something that's of particular interest to myself at the moment is the use of spit hoods, which are being increasingly used in the UK because concerns about infection, for example, coughing. Well, in the past, it's been suggested that hepatitis B or HIV can be communicated by spitting. In fact, the actual risk is very, very, very low, so low as to be almost negligible. But there's been a resurgence in the use of spittlers because of the concerns about COVID-19. The spittlers that are marketed, as far as I'm aware, none of them have actually been tested to see whether or not they are COVID protected. I don't expect them to be so. And there's a recent documentary which you may wish to take some time out to watch, which is a young man called Alan Nagata, who died in New Zealand some time ago when a spit hood was applied. So again, all these things have risks. It's often each of the individual things, the irritant spray, the taser, may not on its own cause a death, but combined with other features, it may result in death or harm. So deaths in both police and prison custody is something that we're very good, I think, in the UK at reviewing. We're not so good at learning the lessons from them, but we have every death in police custody, every death in prison custody is reviewed by, in the case of the police, by the Independent Office of Police Conduct, and in the case of deaths in prison, in longer term custody, by the Prison and Probation Ombudsman. And all the data, all their findings and reports can be accessed online. And that's what I think all states should do. And I think the problem we have is that even if that is done, and the IOPC produces annual statistics, even in the UK where there is good oversight, there are still unacceptable amounts of deaths in state custody. And this slide just shows a report that looked at over 14 years, there are about 8,000 deaths in state custody. Many of those are in patients detained under the Mental Health Act, 34% in prison settings. It can't be acceptable that people die in state custody. They are there for a reason, admittedly, but their rights should be protected. And so any state should do its best to ensure that every death is investigated properly. And if there are lessons to be learned, or there are sanctions or criminal cases to be put against, for example, police officers, they should be followed through. This is just a screenshot of just to show how low are the numbers of deaths in police custody in the UK are. They're perhaps only 60. The problem is that every single one of them is obviously a tragedy. Everyone will have substantial media coverage, but the problem is the criminal proceedings, if they take place, the inquest, may not take till something like 3, 4, 5 years later. So a lot of the learning is lost. Deaths by hanging, these are the kind of areas where we've actually been able to reduce in police custody, where things go wrong, where people have self-hung by, for example, wrapping around a light frame or the wicket in a door. And that's probably because of the increased use of CCTV in the last few years. There is a commonality around the world, but the commonality is not so much on numbers, but on the nature of what happened. So this study from India, from Maharashtra, published in the Journal of Forensic and Legal Medicine this year, explores 108 autopsies occurring in police custody or following police action. And this reports the majority of victims committed suicide in police custody. The majority that did so by hanging. But one of the biggest concerns is blunt force injuries were a frequent cause of homicide in police custody. Now, I don't know, you yourselves may have your own views, but I think that states generally are poor in ensuring that police have either the training or the understanding to prevent deaths occurring. And we have to be, very clear. We have to understand that some police officers, and I'm talking in every country around the world, abuse the powers vested in them. And I believe that if they do, they should be held to account for that. And we've seen a lot of activity this year where such concerns are raised. Just out of interest, a report looked at deaths and serious incidents in police custody in the UK a couple of years ago, but there was a rather nice report, a review of the international evidence. That's well worth looking at if you haven't seen it. And then, very sadly, in the last 2 days here in the UK, something that's never happened before, a police sergeant who is well known to me, who's an absolutely lovely man, Matt Bratana, who I worked with over a number of years. A prisoner came into a police custody suite. Circumstances are not exactly clear, but Matt was shot and killed a couple of days ago. So again, that will need to be investigated. What were the circumstances? Are there lessons that can be learned? And one can only hope that, as with all other deaths in custody, but including Matt's, that some good will come out of what is always absolutely tragic circumstances. So, just perhaps to talk a little bit now about miscarriages of justice, which I think is very much an integral part of the role of the forensic physician. This is, The Guardian is one of the UK national newspapers, and it reports about 5 years ago how the forensic science regulator, who oversees forensic science in the UK, wanted to review all sexual assault cases because of concerns about poor practice. That included sampling, interpretation, analysis, so the whole spectrum coming from the forensic physician through to the laboratories and through to their interpretation. I'll just finally go through a sort of range of the kind of cases which forensic physicians, perhaps at a more senior level, may be involved with, and some of the examples that I've done. So we get involved, a lot of people are detained under terrorist legislation. And so Barbara Ahmad was arrested some years ago, and there was a requirement for him to be extradited to the United States. One of our roles will be to assess and to ensure his care is appropriate in custody, so there can't be any suggestions that, for example, a confession or anything was obtained through torture. So we are there to act as guardians to try and ensure that things like torture, cruel, inhuman and degrading treatment don't occur. And if we think that there is that possibility, or there is behaviour that we believe is concerning, then we have a duty as forensic physicians to escalate that to appropriate people. Another thing that we may do as forensic physicians is to review older cases. I was asked a couple of years ago to put together a team where we were looking for people, looking at Kenyan nationals who had been subject to villagization. We're talking about 1956, the late 1950s, where the British Army and the Kenyan police were alleged to have mistreated, raped and tortured a number of Kenyan nationals. And myself and the team went to Nairobi and assessed a number of the Kenyan nationals, some of whom were in their 90s, to look and see whether we could identify, for example, by marks and scars, whether or not the medical evidence and the psychiatric and psychological evidence supported their accounts. This was never tested in court, although from my assessment of the patients, the individuals I see, I have no doubt that the accounts they gave were accurate. But the court case was thrown out because of the Limitation Act, or it was concluded it was not appropriate to hear the case. Deaths in custody, and sometimes deaths not in a police station but elsewhere, may be things that I may be asked to look at the course of events and see whether anything could have been preventable. Jimmy Mabenga was an Angolan who was being deported, and he died having been restrained on a British Airways plane, and he died as a result, as a result of being restrained. There was a criminal case against security guards, but they were acquitted of that because the jury concluded that although the facts were evident that they had acted that they couldn't be found guilty to the criminal standard and the proof, and were acquitted. But again, myself and forensic pathologists explored this, and this went through a number of settings, including a coronial inquest and then subsequently a criminal trial. Sean Rigg was a young man with mental health issues who died as a result of positional asphyxia, and a number of other concerns were raised. Again, high-profile cases where really it's essential that independent opinions try and assist the court to the best of their ability, so the courts can come to what is the right decision. This is another case where, although I'm not a pathologist, I have a surgical background and anatomical background as well, where I may be asked to then comment on, for example, this cases where it's an alleged suicide, it's being challenged at the moment. Man was found in a car with what was believed to be a single entry wound to his neck, and the question is whether or not this had killed him. When he was taken to the post-mortem, 2 entry wounds were identified, and the question here, because there are concerns about whether or not, number one, he could have fired 2 shots into his neck, would each, and my view is that each of these particular wounds, he would have been rendered incapable by either one. So the question is, what were the actual circumstances? And that's being explored in a jurisdiction. I can't say more than that at the moment. One that I can do is looking at a police custodial death, and this was in Diani Police Station in Kenya, on the east coast of Kenya, little local town. A young man called Alexander Monson, 29-year-old British Kenyan, was found collapsed in a police cell, having been arrested for allegedly smoking some cannabis. He was taken to hospital and died, handcuffed to a hospital bed. It was said that he died from a drugs overdose. I was asked to look at this. I got with a legal team, Fran Wiley and Ian Daniels, and we explored all the evidence for the inquest. He died in 2012. I think this was 2015. We were asked to look at it. And what we found, in essence, after considerable effort in behalf of the family and with the family, trying to get hold of the facts, we found that post-mortem findings were ignored and anyway misleading. Toxicological findings were fabricated. Toxicology that was reported on him was taken on unrelated specimens. False witness statements were made, and then the documented, in effect, custody record, termed the current book of the cell register, whose existence had been denied, we were able to get hold of, and it showed that, in fact, there was no suggestion at all that Alexander had been under the influence of drugs. And so, in this case, what went wrong? Everything had been assessed, and he'd been documented what had happened to him at the time, but the sampling had been messed around with. Whether it had been substituted, we don't know. We don't know who'd done that. The interpretation was either accidentally or deliberately misleading. The police process was very flawed and corrupt, and the police oversight process seemingly so as well. The legal process, however, which involved undertaking an inquest, took its time but did go ahead appropriately, and I ended up in 2015 giving evidence in Mombasa Crown Court, explaining the findings that we'd independently come to, that we felt that some evidence had been fabricated, some had been ignored. We couldn't say why. And then the senior principal magistrate, who's the coroner, Richard Adenyo, after 3 years, and the process of the inquest took about 3 years, came to the conclusion, the inquest conclusion, that Alexander hadn't died by a natural death. He hadn't died as a result of an overdose of drugs. He died, as our team had concluded, from having been assaulted. We didn't know who by, but he concluded that he was assaulted by the police, and that he recommended that police officers were charged with murder. That trial is still ongoing some 3 years later, and so I can't say what the outcome will be. Now, there's a slight pause here. So I have a slight internet problem, which is also why this is being recorded. We have terrible weather conditions at the moment. I have to just step out of this. There we go. And so there's another case which will be familiar to many of you at the moment. And I can't talk too much about it, but I was asked by Rabia Khan, Jia's mother, to look at the case of Jia, Nafisa Khan, because her mother felt that the account of the police that she died by suicide was not correct. Mum and family have given me permission to use these slides, and I know they've been on in the public domain anyway. But there were a number of factors, in essence, about the whole case as to whether or not this was definitely suicide. Now, some reports say that I've said that this is a staged murder. I think it's always difficult when there's a lot of social media. I don't believe it's right to get engaged on social media. All I can say is that I believe that what is very clear is that it was wrong, that there was an assumption made that Jia died by suicide, and that it should have been considered at the beginning that there were perhaps alternative explanations. What I haven't said is that I believe there is definitely an alternative explanation. So I've not excluded suicide, but it should have been properly investigated at the time. And in that particular case, in Jier's case, which as you know is still ongoing and has been escalated as a result of other deaths in India, was that there is no doubt the initial assessment by the police or anyone else was not done properly. Documentation was not done properly. Sampling was not done properly. The evidence collection was not done properly. The interpretation was not done properly. The police process was flawed. The police oversight process is flawed. The Central Bureau of Investigation has, I would say, as a independent observer, there are some concerns there. What we don't know as yet, because the process is still ongoing, cases are ongoing, and it's not appropriate for me to comment on them, but the legal process is ongoing. And my view generally is that in most countries, although the law takes an awful long time to be pursued properly, generally, as for example with Alexander Monson's case, ultimately at least some proper investigation is done. So I don't know what the outcome will be. I've advised Jier's family as much as I can, but it's important to go back to my initial points. The forensic physician, like the forensic scientist, the forensic odontologist, the forensic biologist, the forensic pathologist, we're not there to determine what the actual end result is. We're part of the jigsaw, or we're a piece of the jigsaw, sometimes bigger, sometimes smaller, but that's what we are. We're not there to make the determination. So if we think of the causes of miscarriage of justice, they embrace all the aspects of what a forensic physician does, and indeed a forensic scientist or a forensic odontologist in our various areas of work. We're engaged with the police process, and that may go wrong. We're there to assess in our particular discipline that we may do that badly, we may omit things. We may document things inappropriately, we may document them wrongly, we may sample badly, we may sample inappropriately, we may not interpret correctly, we may interpret not only incorrectly but completely wrongly. The prosecution process then may be affected by our interpretation and our findings, as might the oversight process. The legal process, if the case gets to court, is then dependent on the prosecution, the defense, and the appeal systems all working efficiently. Sometimes they don't. But all of those things, if people are trained and there is proper oversight and people are independent and they recognize their roles, things should go all right. The things that you can't deal with, and the things that I think are probably the most concerning in every country in the world, in every jurisdiction, are number one, malice. Somebody wants to cause a miscarriage of justice, which really in criminal setting is either a guilty person getting acquitted, that's a miscarriage of justice, or a non-guilty person, an innocent person getting convicted. That can be achieved if you have malicious individuals in any part of this process. And then on top of that, I think there is a broader aspect of corruption generally. And it may be financial, it may be political, and my view is they're always interlinked. So I think we're there to try and make sure that all of this, in as much as we can, works reasonably well. And I'll just give the last couple of slides. There's two judgments, in cases where the quotes I like quite well. So why do we do appropriate forensic medical assessments? Or why do you do appropriate assessments in your role? So this determination, or this judge said, and this was in a case where everybody assumed something had happened when in fact it did not. And he said, as everybody who has anything to do with the law knows, the path of law is strewn with examples of open and shut cases which somehow were not, or of unanswerable charges, which in the event were completely answered, or of inexplicable conduct, which was fully explained, or of fixed and unalterable determinations that by discussion suffered a change. And I think that last one is particularly important for those of us who are working in the field. We may come to a conclusion, we may believe that this is what happened and this is our interpretation, but we should always be open to revising and changing our opinion. And that is the mark of an effective and appropriate forensic specialist and somebody working in the forensic setting, never to think, I'm always right. And again, that is backed up by this judgment. And again, this statement, which says justice according to the law demands proper evidence. By that, we mean not merely evidence which might be true, and to a considerable extent probably is true, but as the learned trial judge put it, evidence which is so convincing in truth and manifestly reliable that it reaches the standard of proof beyond reasonable doubt. So those two slides are the most important thing I think about how we should all be working. So what are my conclusions? My final slide, and I'm sorry to have taken so much time, and I welcome questions afterwards. For those of us working in forensic disciplines in settings such as police and prison custody, sexual assault referral, criminal justice generally have a unique and privileged access to settings in most areas where different types of miscarriage of justice may occur. So those of us working in such settings, and so although I'm talking about forensic position, it applies to all of us and all of you. We should remain vigilant and always be prepared to raise issues where there appears to be any risk of some type of miscarriage of justice. And I genuinely believe that those of us working in forensic disciplines should consider ourselves as gatekeepers for ensuring the justice system works properly. Thank you very much. I say I welcome questions and I'm happy to deal with them either now, but please feel free to email me at any stage and I will address them and contact.
Thank you so much, sir, for taking a wonderful session. Now I request participant, if they have any question, they can ask with our esteemed speaker, Dr. Jason Payne. So few participants, they have typed the question in the chat box. So if I'm just going through the one by one question, taking a first question, this is the question. Yeah, so whenever it is possible to detect the presence of any drugs in bite marks of suspect in victim body, if it is possible, how long the drug stay in the victim body?
It's a very good general question. I think that it will depend in many respects what the drugs are and how samples are taken from those bite marks. So, for example, somebody may have, as I think I showed in one of the images, there may be loss of tissue and that person may require surgery. If there is consideration that if we're looking at whether or not the biter has drugs on them, then there is, I suppose, and I'm not a toxicologist, I'll be very clear about that, but if there is, for example, a lot of saliva and other biological fluid, then it is possible, I guess, that drugs could be isolated. And again, in terms of the victim, again, samples, it might be possible to do screening tests, but I suspect it would be very difficult to get good quantitative results. I think that in general, if you're considering that there may be drugs involved in terms of either the complainant or the suspect, that the best option, as usual, would be to get a blood sample to do that toxicology. But it's an interesting question that I've not considered before.
Yeah. Another question we have: recently, the Russian opposition leader was allegedly poisoned by a novichok agent. What are these agent mechanism of action, effect, and how to estimate them?
Yeah, interesting. Well, we had an episode of Novichok poisoning with two people in the UK a couple of years ago, and we know that the Russian opposition leader has just been proven to be poisoned by Novichok. Well, Novichok's an agent; it's an organophosphate anticholinesterase inhibitor. So in effect, its effects are to result in raised acetylcholine concentrations, and in terms of skeletal muscle, you get involuntary neuromuscular contraction. But the end result, very simply, is either cardiac or respiratory impairment and or arrest, and the treatment is predominantly supportive. Again, the details, because there are so few of these cases, it's a we know that it's a very, very nasty substance, and you need very small amounts of it. In the UK, I think it was two police officers who attended the house where the two victims had been poisoned, himself sustained, or two of them sustained, I think one or two sustained contamination just simply from handling, I think, a door handle. But in terms of how the drug is assayed, I don't know. That's again a matter for a toxicologist. But it is rare, but it is very clear that it's believed that it's a Russian-generated agent, but it's been used in a number of high-profile cases now. I understand also, I mean, that the Russian leader of the opposition, he's now recovering, and some of you may have seen a news clip where he was photographed. I think he's in Germany, but he's got some residual weakness, which may or may not be entirely recoverable.
Yeah. Next question we have: does the inquest autopsy procedure crime scene recorded in all custodial cases by Suresh Sethi?
Yeah, interesting. The custody deaths. So we have to differentiate. If I'm talking about the United Kingdom, we have to differentiate Scotland, which has its own jurisdiction, and I think, as is mentioned in a previous question, there's a procurator fiscal system in Scotland, but in England and Wales, where I practice predominantly, we have the coroner, and the coroner is an independent judicial officer, and uniquely the investigation of a custodial death is done via an inquest, which is a non-adversarial inquisition. It's an investigative procedure, and around the UK there are probably, I think, 100 or so jurisdictions. Coroners have their own way in investigating them, but if somebody, say, dies in police custody, then the scene will be preserved as in the same way as a crime scene. Whatever CCTV, or a lot of our police officers now have body-worn video, all of that will be seized. Statements will be taken from anyone who has been involved in either the care or arresting that individual. So there is a full investigation. But the problem that you have with all custodial deaths is that because there are a number of routes in which they are investigated. So there will be the coronial inquest route. There may be an employment-related route from the police setting itself. There may be civil negligence claims. So there are normally a number of legal processes ongoing, and the outcome, the reasons why, or the final determination of how that death occurred, and for example, the post-mortem and the autopsy procedures are in fact the most simple part of what's been done, because that's established quite early. But it may take 4 or 5 years, even with our system, which is supposedly relatively efficient. And the other thing is that the nature of investigation is that that many people are unhappy with the outcome of many custodial inquests, and sometimes, very rarely, for example, a police officer or a member of the police personnel, or indeed a doctor or a nurse, could be subject to charges of criminal manslaughter by gross negligence for failing to treat somebody properly. But there have been no convictions, as far as I'm aware, for example, of police or indeed doctors for criminal manslaughter. But they are investigated to the same level as a criminal trial.
Taking the next question by Dr. Sumon from Bangladesh. What about the prevalence of custodial death in United Kingdom?
Yeah, again, a good question. The number, custodial deaths are divided into 2 main areas. The police, which is our short-term custody when somebody's immediately arrested, and then the police have generally 24 hours to make a decision on whether people are going to be charged. So if somebody dies within that window, or when they're being arrested, that counts as a police custody death. Our numbers are very low now. We have about 1 million people who are arrested each year. We have probably 20 or so police custodial deaths per annum. It's gone down from 60 down to, it went down to about 15 or so on average per annum, but it's risen up a little bit. Most of our reduction in deaths is the reduction in self-harm. So people hanging themselves in a police cell, and that was reduced because of the introduction of CCTV. And then if you take the prison population, that's a much bigger, so the long-term prisoner who's been convicted or is on remand awaiting trial, and the number of deaths there goes into, I think, several hundred, but a number of those will be natural deaths. So for example, we have an older prison population at the moment. The age of prisoners is going up. I was reviewing somebody a couple of days ago in prison who's 80, who's been charged with murder, but he's got multiple comorbidities. And my view is, I was being asked whether he was fit for trial, and my view is that he's severely frail. But so we have people who die natural death because they were going to die anyway and they just happened to be in prison. And then you have the preventable ones, which may be self-harm, as a result of access to drugs or alcohol in prison, which is even in our prisons are rife with drugs and alcohol. And the other big group, which has become much more prevalent recently, is prisoner on prison attacks, not always murders, but certainly grievous bodily harm, serious bodily harm. And that seems to be linked in with the increasing use of novel psychoactive substances, particularly and other things like synthetic cannabinoids such as spice.
Thank you so much, sir. I think we have taken all the questions of today's session. Although we are in the virtual space, but I request, along with my co-host, Dr. Pooja Chakravarti, to accept the certificate of appreciation from Sherlock Institute of Forensic Science for delivering such a wonderful lecture.
Well, thank you. Can I also apologize to everybody who's listening? If it was bad for you to have to listen, it was even worse for me. But the reason that it had to be recorded in advance is, as I say, because I have got we have got such bad weather at the moment in the east coast of England that we're losing connections all the time. So I apologize for that. And I hope that if you have taken anything away from this, that the audio quality didn't upset it too much. And I really appreciate being invited to speak. And I think you're doing a fantastic job, and I'll certainly sign in and listen to future speakers.
Thank you so much, sir. Thank you. I thank you all my team member for putting their effort to reaching a different social media, so that we are getting more and more people benefited by lecture by esteemed speaker like Jason Payne and many others. So we are conducting every Sunday. So I thank you, my team member Afreen, Amala, Amber, Anmol, Aarti, Dr. Janita, Dr. Pooja, Falak, Kaneri, Kratika, Lakshya, Rashika, Mebal, Neha, Nimisha, Pallavi, Priya, Raj, Ruchika, Shaza, Shivani, Tanya, Vaishnavi. So our list is long. I request all the participants, those who have registered, they can download their certificate from the website forensicevents.com and /download certificate. You can see this link on the website. Here you have to click. After clicking, you have to put your email ID, registered email ID, and you can download your certificate. Only the registered participants, those who have earlier registered, they are only can download the certificate. Even we have a several WhatsApp group where many of you have joined this session, but you have not registered. But if you have registered, you can download the certificate. With this, on next Sunday, we have another session by Anna Barbaro on the Women in Forensic. And she is the president of the Worldwide Association of Women Forensic Expert. I welcome you all on the next Sunday with my lecture moderator, Janita Jasuja. With this, I invite you all in the first International Biannual Symposium of Association Forensic Odontology for Human Right, which we are going to conduct in September 2020. With this, I request my co-host, Dr. Pooja, to give a vote of thanks to our esteemed speaker, Dr. Jason Payne, sir. Dr. Pooja.
Thank you so much, sir, for being with us. I know that there were certain issues with today's session, but I'm sure ultimately everything that ends well is good. So I'm really thankful to you, Jason, sir, for sparing your valuable time with us. It was indeed a pleasure and an honor for us to host you here. Thank you. And last but not the least, I would like to thank all my participants here who took out their valuable time to join us. And in spite of the technical errors, you stayed along with us. Thank you so much for being there.